Okay. Hello guys. So topic for today is vitamin B complex. So you should understand this vitamin B complex is a very vast topic and one of the easiest scoring part of pediatrics. So this will help you in theory as well as practical where you have to tell about the head to toe examination and mostly in the bedside clinics. This is of very helpful topic if you know this thoroughly. So let's start with this. So I have divided it into two classes so that we'll discuss about each vitamin in complete detail and there are no doubts left. Okay. So let's start with the first part today, that is vitamin B complex. Now you should know that vitamin B complex means it is a group of 8 water soluble vitamins. When we take vitamins, we divided it to water soluble and fat soluble vitamins. Fat soluble vitamins being vitamin A, D, E, and K. So vitamin A and vitamin D we have already discussed. E and K you can read it up on your own, nothing much for discussion. Whereas the water soluble vitamins are the B complex vitamins and non B complex vitamins. In B complex vitamins, those 8 will come. In non B complex vitamins is your vitamin C. So next we'll touch upon this part of the nutrition. Now coming to B vitamins. So it's a group of 8 water soluble vitamins. Because it is water soluble, it is not stored in the body. That is, it gets excreted in the urine. So that is why it needs nearly daily intake. That means for the deficiency of vitamin B complex to set in, it requires hardly weeks, maybe 2 to 3 weeks, the child will have deficiency symptoms and signs. Okay. And this is a thumb rule that you can follow for all the vitamin B complex. If anybody asks you the source of vitamin B1 to all the 8 vitamins, you can always tell animal proteins, mainly dairy proteins, that is milk and milk products, and then is green leafy vegetables and beans and legumes. So that is why treatment of all vitamin B complex deficiency is again rainbow diet. That is, we tell in the plate all color of fruits and vegetables should be there. So we will just advise rainbow diet so that they include all the green leafy vegetables, carrots and other things, so that all the vitamin B complex are supplemented. Now, what is the function of it? Grossly, you can remember that they are involved in all catabolic as well as anabolic metabolisms, mainly all redox reaction. That means reduction as well as oxidation reactions that happen in ATP production, that is your Krebs cycle or TCA cycle. They are all involved even in your ETC, that is electron transport chain. So all main functions of the cell, every cell of our body will have TCA cycle and ETC in place. So in all these cycles, vitamin B complex play a major role. Okay, so let's start with the classification. So you should just remember these names: B1, B2, B3. There is no B4. Next is B5, B6, B7. There is no 8. So 4 nahi hai, 8 nahi hai. Then is your 9, 10 and 11 is not there. So it is directly 12. Okay. So B1 is thiamine. B2 is riboflavin. B3 is niacin. B5 is pantothenic acid. B6 is pyridoxine. B7 is biotin. B9 is folic acid or folate. Okay. And B12 is cobalamin. Choline and inositol are also part of B complex, but they are not given any specific names. We'll touch upon this later on, but you should know these numbers also. Okay. Next, let's start with thiamine. Now, thiamine is vitamin B1. So basically, thiamine is involved in carbohydrate metabolism. Where in carbohydrate metabolism, whenever glucose has to be broken down to pyruvate, which further enters the TCA cycle to give us ATPs, correct? So there are 3 main enzymes which has thiamine as its cofactor in the form of thiamine pyrophosphate, TPP, okay, plus HMP shunt, and thiamine is also important in the regulation of acetylcholine and GABA. By regulation, I mean both the production as well as maintenance of levels of acetylcholine and GABA neurotransmitters. It is involved. So that is why there will be problems in nerve conduction if there is vitamin B1 deficiency. Okay, so where do we find this deficiency? In generally, all vitamins are absorbed through intestine. So if there is any malabsorption disorders, then you can have vitamin B complex deficiencies. Plus liver disorders where there is cholestasis, because of which the requirement of the body of vitamin B complex increases, that time also you can have vitamin B deficiency symptoms. Plus, alcohol intake is known for causing vitamin B complex deficiencies. So this is the places where thiamine pyrophosphate works. So whenever glucose is broken down to lactate, if there is aerobic metabolism happening, then it is converted to acetyl-CoA, which enters the Krebs cycle. So here pyruvate dehydrogenase wants thiamine as a cofactor. In Krebs cycle, alpha ketoglutarate dehydrogenase also wants thiamine as cofactor. If there is anaerobic metabolism, there is lactate production. Okay, so that means whenever thiamine is deficient, you can expect lactate to go up. Why? Pyruvate will choose the alternate pathway because the cofactors are absent. Okay, then this is your gross depiction of where all thiamine has its role. So you can see that the glucose is broken down to pyruvate through our glycolysis. Intermediate formed is glucose 6-phosphate, which can get into pentose phosphate pathway. Now, pentose means 5 Cs, that is 5 carbon chain pathways. Glucose is 6 carbon chain pathway, correct? So, in this 5 carbon chain pathway, with multiple steps, it will get converted to ribulose and thereby help in production of nucleic acids, correct? And this pentose phosphate pathway wants transketolase. Now, thiamine pyrophosphate is a cofactor of this enzyme called as transketolase, through which the production of ribulose and thereby the nucleic acids happen. Plus, this also leads to the production of NADPH, which is nothing but vitamin B3, that is niacinamide. Okay. So, this is one place where thiamine is important. Point number 1. Point number 2, as we discussed in the previous slide, it is pyruvate dehydrogenase, through which it gets converted to acetyl-CoA in an aerobic metabolism and then enters the TCA cycle. So the moment your thiamine is deficient, pyruvate will get shunted towards the lactate pathway. Okay, in the mitochondria, once the acetyl-CoA enters the TCA cycle, at the level of alpha ketoglutarate dehydrogenase, thiamine pyrophosphate is needed. Okay, that means if this is also deficient, the conversion further doesn't happen, thereby affecting the production of GABA. Now, alpha ketoglutarate is also very important for the production of GABA and glutamate, which are again neurotransmitters. Okay, so if this is also production problem, then there will be problems in nerve conduction. Then one more place where you can see thiamine pyrophosphate is your branched chain amino acid deoxygenation. So whenever your branched chain amino acids are broken down to keto acids, then by dehydrogenation, they have to be converted to acetyl-CoA. This requires thiamine. So that means your complete protein breakdown also doesn't happen whenever thiamine is absent. So these are the major places. This is point number 3. This is point number 4. So these are the major places where you'll have problems if the thiamine is deficient. So that is what they have shown. If this is deficient, the neuronal damage happens because nucleic acid productions are also less, plus your GABA production also is less. So nerve conduction is a problem. Whenever pyruvate dehydrogenase is not there and there is lactic acidosis, this helps in dysfunction of mitochondria. So overall mitochondrial dysfunction sets in, leading to deterioration of the child or a person, correct? Plus, this is very important for myelin sheath production. Again, thereby related to your GABA and glutamate plus free radical production, leading to nerve conduction problems. Okay, and you know mitochondria. So this whole process will happen in literally every cell of our body. So if this mitochondrial dysfunction happens predominantly in heart muscles, that is when we get wet beriberi or the cardiac failure symptoms that we have. Okay, plus this protein or the amino acid breakdown also doesn't happen, leading to accumulation of this, thereby leading to deficiency of Krebs cycle and again increase in the production of lactate. So these are all the main cycles through which thiamine deficiency works. Okay, I hope this is a very important slide to understand thiamine deficiency. Okay, so what are all the conditions where there will be deficient? Like I told, either you have GI problem, that is your intestinal malabsorption disorders that can cause decreased absorption of thiamine, or if the intake is less, if you have a staple diet, especially in refugee camps where rice is the only source present for carbohydrates and proteins. So that is why they end up eating only staple food as rice. That is why having a thiamine deficiency. Or if there is increased requirement, so either there is decreased intake. If there is intake, there is decreased absorption, like in alcoholic liver disease, or your liver problems like cholestasis, or your GIT disorders like intestinal malabsorption problems, or there is increased requirements, as in pregnancy, fever, if a muscular activity is more, or if there is hyperthyroidism, where the baseline basal metabolic rate is also high. Correct? So then these are the conditions where deficiency can be seen. Okay, next coming to sources. So what are the sources I told you? Grossly you can remember it as animal based, dairy products, legumes and beans. Correct? So the same thing you can remember, legumes, and especially in thiamine you can remember it as rice. Rice is the main source of thiamine. Oat and wheat also is a source of thiamine. In non-veg, it comes to fish, pork, and poultry. These are all the sources of thiamine in non-veg sources. Okay. Then there is something called as thiamine antagonist, especially so in areas where there is excessive intake of tea and coffee. Even soon after having lunch or dinner, they end up taking tea and coffee. There also you can see thiamine deficiency, because tea and coffee is a thiamine antagonist, reduces the absorption of thiamine. And certain kinds of fermented fish in coastal areas can predispose to thiamine deficiency. And in fact, it is almost seen that most of the coastal areas have high rates of thiamine deficiency because of this reason. Okay. So these are the causes of deficiency. Other causes where there is increased requirement is malignancy, severe acute malnutrition where the intake is less, plus there is underlying illness because of which there is malnutrition, malnutrition induced reduced intestinal absorption of vitamin B complex, post surgery and critical illness, because here also there is increased BMR for a short time, increased basal metabolic rate for a short time. Correct? So now when it comes to deficiency of thiamine, you should remember few words, that is beriberi, which is again of two types, that is either wet beriberi or a dry beriberi. There is something called as oriental beriberi. There is something called as occidental beriberi. There is something called as Shoshin beriberi. Shoshin beriberi. Okay. There's something called as TRMA, or also called as Rogers syndrome. Rogers syndrome. All of these are neat questions. That is why I've touched upon all these a little more. Okay. So let's go to each of them in detail. Now you should know what is wet or dry beriberi. Now by the word only you understand, wet means there is edema in the body. So whenever thiamine deficiency starts, the early symptom is fatigue, apathy, irritability. Child is generally dull with loss of appetite, nausea and abdominal discomfort. Then it can become either wet beriberi or it can become dry beriberi. Now wet beriberi means there is cardiac involvement. Cardiac muscles will have mitochondrial dysfunction, thereby leading to fatty degeneration of the myocardium. This in turn leading to a picture called as congestive cardiac failure. That means heart is unable to pump the blood to supply all the body organs with oxygenated blood. So what happens once there is congestive cardiac failure? There is edema that sets in the body. Dependent edema starts. The child will be cyanosed. Child will be tachypneic, that is dyspneic. Child will have tachycardia because heart will try to compensate by increasing the rate. There will be right-sided heart enlargement. There will be edema. Now, if this is not treated immediately, it can even cause death. Okay. This is one variety which is called as wet beriberi. That means predominantly having edema as a complaint. When a child goes to the other pathway, that is the dry beriberi. Now, what is dry beriberi? By the word dry, you realize that there is no edema here. So, predominantly it is CNS, and that is central nervous system, and peripheral nervous system problems. It is a peripheral nervous system problem. Okay. So what happens here, like I've showed you in the previous chart, that thiamine is very important for myelin production. It is very important for GABA and acetylcholine productions. Plus, it is very important for your CNS neuron myelination as well as neuronal functioning. So once that is affected, first to start will be peripheral neuritis. That means peripheral nerves will have delayed conduction and abnormal functioning, leading to positive symptoms like tingling, burning, paresthesias. Negative symptoms like numbness. The child will lose its sensation of pain and all, because of which there can even be ulcers. The deep tendon reflexes will be depressed. There can be even vibration sense problem. Plus, the child will have transient, because the nerve is not supplying it well. The muscle can even go for tenderness and atrophy further if it is not taken care. Now, at this stage, if we miss the child, then you can even have CNS symptoms like ptosis, where the third oculomotor nerve is involved. There can be even optic nerve atrophy. There can be laryngeal nerve palsy, leading to hoarseness of the voice. And such babies, when they come with aphonia. There is no production of voice and either hoarse cry. They can only come with the complaint of hoarse cry and aphonia also. And there will be loss of coordination. So predominantly, either you have nerve conduction issues, wherein you have tingling numbness, negative tingling sensation, paresthesias, negative symptoms like numbness, and because of which you can have muscular myopathies. Okay, that is muscle tenderness and muscle weakness, which if not treated will go for CNS symptoms, wherein there will be cranial nerve palsies and even laryngeal nerve palsy. Along with that, depressed sensorium. Now, all of this is happening. Child will definitely be depressed and the sensorium will dip. There will be apathy. There will be loss of interest into the surrounding. So, this is how a dry beriberi presents. So, generally, wet beriberi will have features of CNS also. That is why instead of just calling it as wet beriberi, we call it as cardiopathy plus neuropathy. So they can even have CNS symptoms. Okay, so this is how your wet and dry beriberi presents. Okay, coming to what is oriental beriberi. Now, oriental beriberi is a beriberi which is present in the oriental areas where polished rice is the staple food. That means the husk is removed and the rice is polished and then used for eating. So then it causes thiamine deficiency, leading to oriental beriberi. So what is the solution? You do something called as parboiling. That means you boil the rice with the husk in it so that the thiamine penetrates into the rice from the husk area, and then remove the husk and package it for use. So that is the solution for oriental beriberi. What is occidental beriberi? Occidental beriberi is a word used for Western countries where alcohol, fast food, food faddism is a common thing, and the wheat that they use is a refined wheat, or in other sense it is maida that is used for their food and pizza and burger kind of a stuff which they have on a day-to-day basis. So that is called as occidental beriberi. Now, what is Shoshin beriberi? Shoshin beriberi is a fulminant form of beriberi which presents like wet beriberi, and if not treated can even cause death in days. So this is the most fulminant kind of beriberi that you see. Next coming to TRMA, that is nothing but thiamine responsive megaloblastic anemia, also called as Roger syndrome. Now, what is this? This is when it is syndrome, it will not have only one complaint, it will have two or more, correct? So, it is a complex of megaloblastic anemia plus diabetes mellitus plus sensory neural hearing loss. Now, you know, in nerve conduction, thiamine plays a role. So, obviously, sensory neural hearing loss is also there. Now, why does this happen? This is a autosomal recessive disorder. That means genetics is involved when it comes to Roger syndrome. So, generally a autosomal recessive disorder because of SCN19A mutation. So, this is a kind of a sodium channel mutation that is seen, where you have the result of which is a TRMA, that is thiamine responsive megaloblastic anemia. Now, in this kind of variety, whenever you give thiamine as a treatment, even diabetes mellitus has reverted. That means the insulin requirement of the child also has disappeared. So that sensitive this is to thiamine supplementation. Next, coming to encephalopathy. Okay, Wernicke's encephalopathy we'll discuss in a little detail. Am I audible? Stuck. Okay, so next coming to, this is what is a dry beriberi and wet beriberi that looks like. So in wet beriberi, edema, there's pitting edema elsewhere, classically telling us about congestive cardiac failure. When it comes to dry beriberi, you see a child who is confused, is not able to talk, aphonic. There is wrist drop because nerves are involved. There is increased weakness. Muscles also have stopped functioning because nerves are not giving any signals to the muscle. There is foot drop. There is numbness of the feet. There is burning and reflexes, and there can be painful and tender muscles. So this is how your beriberi presents. So Shashin beriberi is a fulminant form of beriberi which presents with wet kind of a picture. That is cardiogenic shock is there. Along with edema, there will be hypotension and severe metabolic acidosis with increased lactate in it. Okay, leading to death if not taken care in slowly. Okay. So why do few have wet and why do few have dry? So this is a question that we all have to ponder about. I did look into a lot of literature, but as such, there is no specific reason why this happens. There is just theories that are formulated. Like if there is a rapid or a severe deficiency, a acute deficiency, generally it presents like wet beriberi. Whereas if it is a chronic, over a long time the child is deficient in thiamine, then it causes dry beriberi. Okay, if there is a pre-existing heart disease, then it increases the risk for wet beriberi. Pre-existing neuropathy or nerve problems increases the risk for dry beriberi. Plus, if there is a high carbohydrate intake, that means a high load of glucose and starch is there, then also the decompensation happens very rapid fast. So that is why the wet beriberi can come. So these are the postulated reasons why there can be wet or dry beriberi. Now, next coming to Wernicke-Korsakoff syndrome, commonly seen in adults. This is not commonly seen in pediatrics. So, more of an adult disorder where along with thiamine deficiency generally happens in a alcoholic state. That is your, if the child is in the, if the person is in acute liver disease or your chronic alcoholism is there in the background, then you can get this Wernicke-Korsakoff syndrome. If this is a spectrum of disease. So if there is thiamine deficiency, this can lead to encephalopathy, which is an acute reversible stage wherein there is first initially there is confusion, disorientation, okay, because of the cerebral edema. It can also be remembered as Goa, correct? So there is global confusion, there is ophthalmoplegia, there is ataxia, okay? And if this is not treated, then it goes for a chronic irreversible stage, which is called as Korsakoff syndrome. So this is how you remember it. Wernicke's encephalopathy, you remember it as global confusion, ophthalmoplegia and horizontal nystagmus, and ataxia. So remember it as Goa. And if not treated, then it goes for Wernicke-Korsakoff syndrome, wherein there is acute loss of memory. Now, because of loss of memory, the person starts confabulating. That means he starts making up theories. If you ask anything he doesn't know, irrelevantly, he'll start talking something. So that leads to a confabulatory psychosis that is commonly seen in Wernicke-Korsakoff syndrome. So this is how a Wernicke-Korsakoff syndrome present. Now, this is Wernicke-Korsakoff syndrome is not seen in pediatrics. So, in pediatric, how does it present? It presents with lethargy or even developmental delay. So, it presents with developmental delay, it presents with lethargy, it presents with acute presentation of ophthalmoplegia, there will be restlessness, there will be CNS symptoms like apnea, seizures, neuropathy, okay, abdominal distension, lactic acidosis, and there can be an acute presentation of pulmonary arterial hypertension. Pulmonary arterial hypertension. Okay, so this is a very similar presentation to Wernicke-Korsakoff syndrome of adults. So Okay. Am I audible here? All right. So I think there was some problem with the another system. Okay. If it is audible, I think till here it's just audible, right? So okay. So this is how I was telling that this was a equivalent of Wernicke-Korsakoff syndrome of adults. In pediatric, it will present with your developmental delay, lethargy, failure to thrive, apnea, seizures. Yes, your PPTs. One second. Now visible? Yeah, correct. So this is the slide where we were discussing this. This is equivalent to Wernicke-Korsakoff syndrome in adults. Okay. So I think I'll leave it here. You can see in the recording if you want. Then coming to cause of death. Generally, most commonly the cause of death for thiamine deficiency is cardiac. There is acute degeneration of the myocardium leading to death. Okay. Now coming to diagnosis. So how do we diagnose thiamine deficiency? Most commonly, all B complex vitamins, it is clinical features. If we have a smallest doubt of thiamine deficiency, we can give a challenge of thiamine, and if the child improves, then it is a thiamine deficient child. Okay. And especially below 1 year, if you have an unexplained cardiac failure without any VSD, PDA, without any acute cause, if the child goes for cardiac failure, then you have to keep thiamine deficiency as your differential diagnosis. What is the definitive way of finding out thiamine deficiency? It is this. The erythrocyte, that is RBC transketolase activity and thiamine pyrophosphate effect will do. If both of it is decreased, then it is confirmatory for thiamine deficiency. Also, when we send lactate levels in blood and CSF, like I already told you, obviously lactate will increase because that's the alternate pathway the pyruvate can go through. Correct? Plus, there is another test called urine excretion of thiamine, which can be checked after giving a oral loading dose of thiamine. So, if the thiamine deficient state is there, then whatever thiamine you give orally will get absorbed and there will be barely any excretion in the urine. We all know thiamine is a water soluble vitamin. So if you give more, it should get excreted. So if that doesn't happen, that also confirms that the body is in a deficient state. And whenever dry beriberi or CNS complaints come, if we get an MRI done, these are the lesions that we see. That is basal ganglia as well as frontal lobe lesions. And definitely this explains why in a Wernicke-Korsakoff syndrome, the patient presents with confabulation, not oriented to the surrounding, not having a social sense, all of that, because frontal lobe is affected and basal ganglia is affected. That is why there will be a lot of movement disorders also. Coming to the treatment of thiamine deficiency. Now, what is the treatment? The moment we diagnose the thiamine deficiency, we give a 10 to 50 mg IM dose, or if the child is admitted, then IV dose daily for at least 7 days, followed by oral maintenance of 3 to 5 mg per day daily for next 6 weeks so that all the complaints settle back. So after this, the cardiovascular response is rapid. That means heart will improve, all the wet beriberi symptoms will improve. However, neurological recovery can be incomplete also. That means once the damage is done, may persist when it comes to dry beriberi or a neurological involvement of beriberi. So at this point, you should also know the RDA, recommended dietary allowance of thiamine, is somewhere between 0.2 to 1 mg per day. So imagine the treatment dose is almost 10 to 50 times. Okay, so 0.2 to 1 mg per day is the RDA. Next, coming to whenever we give thiamine, in a case of Roger syndrome, the diabetes mellitus also can revert, leading to no insulin requirement after thiamine. Okay. Plus, in a thiamine responsive pulmonary arterial hypertension, also there can be a rapid response. That means the moment you give thiamine, the pulmonary arterial hypertension reduces and the child improves, the CCF also improves. So this is how we treat the thiamine deficiency. Next, coming to the prevention aspect. So how do we prevent the thiamine deficiency? First thing is give rainbow diet in mothers. so that if mothers are not thiamine deficient, babies also will receive it in mother's milk, mother's own milk. Correct? Next, coming to parboiling, that is boil the rice along with the earth and then send it for processing. So this has almost eliminated the oriental beriberi. Okay. Then at home, what all you can do, you do not discard the water that is used for cooking of rice. Do minimal washing of the grains because all these vitamins are water soluble vitamins. You remember, less washing, more vitamin will be retained. And reduce cooking time because thiamine is a heat labile vitamin. Plus, give thiamine supplementation in high risk groups, like if the child is having a malnourished state, diagnosed with any malignancy, has any malabsorption problems, has cholestasis, then prophylactically give thiamine supplementation. So, this is about the thiamine, and these are few thiamine related questions of NEET. Now, one I have discussed with you, that is Roger syndrome, where there is SLC19A2 mutation, where the problem is in the thiamine transporter. Now, thiamine transporter is problem. That is why megaloblastic anemia, diabetes mellitus, and sensory neural deafness comes. We give very high doses of thiamine as a treatment for it. So these are all to be remembered. Second one is a biotin thiamine responsive basal ganglia disease. So only basal ganglia is predominantly involved here. This is also problem with thiamine transporter 2. And this presents with episodic encephalopathy. That means whenever fever is there or any other trigger is there, child is completely dull and encephalopathic, but post recovery it improves. So if biotin and thiamine is given, there is a very rapid improvement. However, because basal ganglia is involved, they'll have movement disorders and they'll have ataxia and other complaints. So diagnosed by MRI. Okay. And next one is lethal microcephaly. If you have a child with severe microcephaly born at birth, this has to be kept in differential, especially if the child is having encephalopathy at birth without any explanation along with lactic acidosis. So usually such babies, we end up giving treatment for seizures. Later on in life, they get diagnosed as a thiamine transport defect, which is a thiamine pyrophosphate carrier is abnormal. So all of these are whole exome sequencing or a genetic diagnosis. Next is thiamine metabolism dysfunction disorder 4 and thiamine metabolism dysfunction disorder 5. So both of this again present with episodic encephalopathy. Here we have predominantly muscle weakness and transient neurological function affection, whereas here it is more like a league disease where there is progressive spasticity and developmental delay with recreation of symptoms. So at least you should know all these names for your NEET function, NEET exams. Okay. So this is about your thiamine deficiency. Next, coming to vitamin B2 or riboflavin. So what is vitamin B2 or riboflavin specially called? It is called as a beauty vitamin. That is, it is involved in the maintenance of skin, hair, and nail. Okay. And this is a yellowish green fluorescent compound soluble in water. Plus riboflavin is derived from two sources, that is ribose, flavin means yellow color. Mostly involved in all redox reactions, reduction plus oxidation reaction, it is involved. Okay. 1 minute. Next is the dietary sources of vitamin B2. So these are the dietary sources. You can keep it in common to remember that it is beans, legumes, and non-veg sources, and predominantly it is milk. So if you have vitamin B2 deficiency, you can always tell the parents to have 1 cup of milk, okay, for the kids. And mushrooms, organ meats, and it is a heat stable. That means if you boil the milk also, it will not get denatured. So it will be stable. Okay, next coming to functions of vitamin B2. So where all it is involved, wherever you have this F, that is flavin in the body, that is FMN, flavin mononucleotide or flavin adenine dinucleotide involved in electron transport chain for ATP synthesis. FAD involved in fatty acid and amino acid metabolism, in antioxidant degeneration, that is in the form of FAD, where it is glutathione reductase activity, again thereby contributing to skin health, again rightly called as beauty vitamin. Then even in the production of NADP, so that is why in the production of B6 and B3 niacin, also involved in homocysteine metabolism. That is why having a healthy levels of vitamin B2 can give you good cardiovascular health. These are all your grossly to remember the functions of vitamin B2. What are the other functions? It is also given, the other functions is like I told you, skin, hair, nail. Similarly, it maintains all the epithelium. So if there is corneal ectasia, that means there is any problem with the corneal epithelium, we have always given a trial of high levels of vitamin B2, that is riboflavin. Plus ART induced, that is antiretroviral viral therapy induced lactic acidosis. Also, we have given trials of vitamin B2 which are found to be helpful. And in migraine prophylaxis also it can be helpful. Plus, especially in neonates with phototherapy, because it is heat stable but light sensitive. So whenever a child is in phototherapy, it degenerates its vitamin B2 levels very rapidly. Hence, this can be an indication to supplement the child with vitamin B2. Okay. So where all do you see deficiency of vitamin B2 or riboflavin? Like I told, either it is intake problem or it is absorption problem. All vitamins getting absorbed from intestine. So either a severe acute malnourished child or malabsorption. If the child is on prolonged phototherapy, or if the child is on drugs like oral contraceptive pills, probenecid, doxorubicin, which is a malignancy drug, and phenothiazine. So if these drugs are used, then also you can have vitamin B2 deficiency. Now these two syndromes are genetic syndromes again. That is Braun-Villet-Van Leere syndrome and Fazia-Londe syndrome. So both are autosomal recessive syndromes. Both have sensory neural hearing loss. Now what is the problem here? It is riboflavin transporter deficiency, transporter deficiency. As soon as the riboflavin is absorbed, it should be carried with its transporter to all the organs. So riboflavin transporter deficiency can give rise to these two syndromes. Just for the sake of your NEET, you should remember these names: Fazia-Londe syndrome or Braun-Villet-Van Leere syndrome. So if a mother has very low riboflavin deficient included in her diet, that can be a high risk for the congenital heart disease incidence in the child. Okay, so these are your clinical features of riboflavin deficiency. You can see angular cheilitis, and you can see it is a red inflamed lung, that is glossitis is there. Along with this, it is a flat tongue, that is the papillae are atrophied. So flat red looking tongue is your riboflavin deficiency tongue, also called as magenta tongue. There is dermatitis because I told you it is a beauty vitamin. There can be maintenance of skin and hair nail problems. So cracks and sores in the mouths and lips. You can even have itching and burning eyes also as a complaint. So other complaints are seborrheic dermatitis, corneal vascularization, because it is involved in maintenance of epithelium. You can have conjunctivitis, keratitis, and photophobia also. So how do we diagnose riboflavin deficiency? Either clinical, that is you supplement with vitamin B2 and see if there is regression of all the symptoms. Then you tell it is a riboflavin deficiency, or there is a test called erythrocyte glutathione reductase, wherein the coefficient, if it is more than 1.4, again a neat question, can diagnose your riboflavin deficiency. The urinary excretion of riboflavin, if it is less than 30 microgram, then also it suggests that there is very less intake of riboflavin. How do we treat it? You give up to 3 to 10 mg. So here also you remember the RDA is same like thiamine, that is 0.2 to 1 mg per day, depending on different spectrum of age. So starting from 6 months where it is 0.2 up to 18 years, it should reach your 1 mg per day. Whereas treatment dose is almost 10 times of it, that is 3 to 10 mg daily. How do we prevent it? Again, rainbow diet, and if it is vegans, because milk is the major source, we tell milk and milk products will prevent riboflavin deficiency. If it is vegans we are dealing with, then we tell them fortified cereals. Okay, I think I'll stop here because next is Chandra Mam's class. The niacin and other vitamins will be dealt in the next class. Okay. If there are any doubts, you can drop in the comment box or you can message me on Insta. Okay, shall we stop it here? Yeah. Thank you.